Today's class is on anti-emetics and prokinetics. What do we mean by emesis? Vomiting, yes. And the anti-emetic drugs are those that help to relieve vomiting. Okay. And what about prokinetic drugs? Any idea? From forward movement of GIT. Basically, they help in the intestinal transit, forward propulsive movement. Now, coming to emesis, vomiting is primarily caused by vomiting center that is located in the medulla oblongata, and the basically multiple pathways can elicit vomiting. There are two major relay centers for causing vomiting. Number one is chemoreceptor trigger zone and the located in area postrema and the nucleus of tractus solitarius. Of them, the chemoreceptor trigger zone is also accessible to blood-borne drugs, metabolites, hormones, etc., as it is unprotected by the blood-brain barrier. The CTZ and the NTH are the most important relay centers for afferent impulses arising from the gastrointestinal tract, throat and other viscera. Now, this is a schematic diagram showing how vomiting is caused. Now, you see any gastrointestinal irritation or use of chemotherapy, radiation, any infection or drugs, what they are causing? They are promoting release of serotonin from the enterochromaffin cells of the intestinal mucosa. And what does serotonin basically is causing? Serotonin basically is in the long run they are acting on the NTS and the basically chemoreceptor trigger zone, causing stimulation of vomiting center and vomiting. Now again basically smell, pain, sight, psychogenic stimuli, they also cause vomiting by action on the higher centers in the cortex. Again, any disturbance in the labyrinth due to basically disequilibrium, what does it cause? They cause stimulation of the histaminergic and the muscarinic receptors in the labyrinth, causing stimulation of cerebellum and ultimately stimulation of vomiting center, causing vomiting. In the emetic response, what happens? Basically, the fundus and the body of the stomach gets relaxed. The lower esophageal sphincter and the esophagus body, they also get relaxed, and there is contraction of the pylorus of the stomach, so that there is basically and the duodenum also contract. There is rhythmic contraction of the diaphragm and the abdominal muscles that compress the stomach and causing evacuation of the gastric content via the mouth. Conditions that inhibit gastric emptying, they also predispose to vomiting. Now, what are the emetics? Emetics are certain drugs that cause vomiting, and these were initially used in case of any poisoning to get rid of the poison. Now, these are contraindicated. These are drugs used to evoke vomiting. They need to be induced only when an undesirable substance like poison is ingested, like powdered mustard suspension or strong salt solution may be used in emergency. How they are acting? They act by reflexly contracting the stomach or irritating the stomach. Now, emetics that can be used, not used nowadays, include apomorphine, that is acting on the chemoreceptor trigger zone, and number 2, ipecac-1Ha, acting reflexly on the stomach and on the chemoreceptor trigger zone. Now, coming to apomorphine, apomorphine basically is the semi-synthetic derivative of the morphine. They have got dopaminergic agonistic action on the chemoreceptor trigger zone. It is given parenterally, intramuscularly or subcutaneously, and they induces vomiting within 5 minutes. Problem: respiratory depression and central nervous system is a major depression is a major drawback, and it should not be used if respiration is depressed. It has also got a therapeutic effect in Parkinsonism because of dopaminergic agonistic action, but is not used due to its side effects. Coming to the second drug, ipecac-1Ha, it is used orally unlike to the apomorphine, the dried roots of Staphylis ipecac uvanha contains emetine and is used as syrup ipecac for inducing vomiting. It is less dependable than the parenteral apomorphine, takes 15 minutes to give response, but safer and is used as household remedy. It acts by irritating gastric mucosa as well as centrally through chemoreceptor trigger zone. Now, contraindications of emetics কোথায় use করা যাবে না? Number 1, in case of corrosive acid or alkali poisoning, because there is higher risk of perforation. Number 2, basically in case of kerosene poisoning, there is risk of aspiration and chemical pneumonia. When the person is poisoned with CNS stimulant drug, as conversion may occur. In case of unconscious patient, emetics should be avoided because that can lead to aspiration. Morphine or phenothiazine poisoning because emetics fail to act. Now, coming to the antiemetics, what are the drugs that are used as antiemetics? Number 1, anticholinergics that include hyoscine and dicyclomine. H1 antihistaminics that include basically first generation, they include promethazine, diphenhydramine, dimenhydrinate, doxylamine and meclizine. Neuroleptics, that is dopaminergic D2 receptor blockers, chlorpromazine, triflupromazine, prochlorperazine. Prokinetic drugs that include metoclopramide, domperidone, cisapride, mosapride, etopride, levosulpiride and cinetapride. 5-HT3 antagonists that include ondansetron, granisetron, palanosatron and ramosetron. NK1, neurokinin 1 receptor antagonist that include aprepitant, fosaprepitant, adjuvant antiemetics that include dexamethasone, benzodiazepines and dronabinol. Now, coming to the each drug one by one, anticholinergics. How anticholinergics basically cause antiemetic action? Because of their anticholinergic action, because of antihistaminic action, anticholinergic action, sorry. It's the most effective drug for motion sickness. Hyoscine is the most effective drug for motion sickness. What is motion sickness? When a person is going by he may go by air, by the sea level, by the car or bus, then due to motion, there is disequilibrium in the labyrinthine apparatus that is causing vomiting because of stimulation of H1 and M3 receptors. Now, most effective drug for motion sickness, brief duration of action, problem is dryness of mouth and sedation and other anticholinergic side effects. Suitable for short brief journeys. Antiemetic action exerted probably by blocking conduction of nerve impulse across a cholinergic link between the vestibular apparatus and the vomiting center, but has poor efficacy in vomiting due to other etiologies. Vomiting can be caused by many etiologies, like by the cancer chemotherapy, by the radiation sickness vomiting, that can be morning sickness due to seen in early pregnancy, that can be due to motion sickness, that can be due to post-operative nausea vomiting. They are mainly effective for the motion sickness and are not seen efficacious in other types of vomiting. A transdermal patch containing 1.5 mg of hyoscine is to be delivered over 3 days. Applied behind the pinna, it suppresses motion sickness while producing only mild side effects. Dicyclomine, they are used as prophylaxis for motion sickness and also for morning sickness. Dicyclomine. It has been cleared of teratogenic potential. Now coming to H1 antihistaminics, that include basically some of the first generation antihistaminics have antiemetic action because of their sedation property, antihistaminic and anticholinergic property. They are mainly useful in motion sickness and to a lesser extent in morning sickness, post-operative and some other forms of vomiting. Their anti-emetic action appears to be based on anticholinergic, antihistaminic, weak anti-dopaminergic action and sedative properties. Now, the drugs that can be used among the antihistaminics are promethazine, diphenhydramine, dimenhydrinate. These drugs afford protection from motion sickness for 4 to 6 hours, but produces sedation and dryness of mouth like that of anticholinergic drugs. Driving is not advisable after taking these drugs because of sedation. By their central anticholinergic action, they block the extrapyramidal side effects of metoclopramide, okay, while suppressing its anti-emetic action. We all know that phenothiazines and other drugs cause extrapyramidal side effects. Similarly, metoclopramide, due to its D2 blocking action, can also cause extrapyramidal side effects, and these drugs can antagonize the extrapyramidal side effects of metoclopramide and also supplement its anti-emetic action. Promethazine is a phenothiazine having weak central anti-dopaminergic action as well. Combination of these antihistaminics with other anti-emetics can be used in chemotherapy-induced nausea vomiting. Now coming to promethazine thiaclolate is one of the oral salt of the promethazine hydrochloride. It is a salt of promethazine and has been especially promoted as an anti-emetic, but does not appear to be significantly different from the promethazine hydrochloride. Doxylamine. Doxylamine is a drug that is considered nowadays as a first line therapy for the morning sickness, okay, in combination with pyridoxine. It is a sedative H1 antihistaminic with prominent anticholinergic activity. Marketed in combination with pyridoxine, it is specifically promoted in India for morning sickness. Although the drug at such use is not made in UK and other countries. American College of Obstetricians and Gynecologists have recommended a combination of doxylamine plus pyridoxine as a first line therapy for morning sickness, and it is FDA approved. Oral absorption slow, half-life 10 hours, side effects drowsiness, dry mouth, vertigo and abdominal upset due to anticholinergic property. Meclizine basically is less sedative, less anticholinergic and longer acting, protects against seasickness for nearly 24 hours. Cinnarizine is used as an anti-vertigo drug, and they have got also action in anti-motion sickness property. It probably acts by inhibiting influx of calcium from the endolymph into the vestibular sensory cells, which mediate the labyrinthine reflexes. Coming to the motion sickness is a common syndrome that occurs upon exposure to certain types of movement. It can be with the car, with the bus, with the train, with the air and moving in the sea. It is thought to be caused by conflict between the vestibular, visual and other proprioceptive symptoms. Although nausea and vomiting is the hallmark, it is often preceded by stomach awareness, malaise, drowsiness and irritability. Anti-emetics with anticholinergic and antihistaminic properties are the first choice drug to be used in motion sickness. Anti-dopaminergic and anti-serotonin drugs are less effective. The drug should be given half an hour to 1 hour before the start of journey. Once sickness has started, it becomes very difficult to control it and higher doses of parenteral therapy has to be used. The antihistaminics are suspected to have teratogenic potential, but there is no conclusive proof. Nevertheless, it is better to avoid in morning sickness. In the early pregnancy, the patient may present with vomiting, nausea and vomiting, particularly in the morning. That is called morning sickness. In those cases, antihistaminics can be used as a therapy, but due to the teratogenic potential, they are better to avoid it. Most cases of morning sickness can be managed by reassurance and dietary adjustment. If an anti-emetic has to be used, dicyclomine is the preferred drug with pyridoxine. Promethazine, prochlorperazine and metoclopramide may be prescribed in low doses. Coming to the neuroleptics, the older neuroleptics like phenothiazines, haloperidol are potent anti-emetics and sedative. because of their D2 antagonistic property. They act by blocking D2 receptors in the chemoreceptor trigger zone, antagonize apomorphine induced vomiting. Many of them have additional antimuscarinic as well as antihistaminic H1 property. Neuroleptics are less effective in motion sickness. Why? Because in the vestibular pathway mainly the histamine and anticholinergic receptors are there, not the dopamine receptors. So the vestibular pathway does not involve dopaminergic link. Spectrum of anti-emetic action of neuroleptics, where they, in which type of vomiting they can be used. Drug induced post-operative nausea and vomiting, they can be used. In case of disease induced vomiting, like in case of liver failure or renal failure. Malignancy associated and cancer chemotherapy induced vomiting. Radiation sickness vomiting, they are less effective. Morning sickness should not be used except in case of hyperemesis gravidarum. What do we mean by hyperemesis gravidarum? Is the excessive vomiting caused during pregnancy, that is basically getting troublesome for the fetus and the mother. Neuroleptics. Most of the drugs produce significant degree of sedation. Hypotension may occur especially on parenteral administration, very important complication. Acute muscle dystonia may occur after a single dose, especially in children and girls. It is already in antipsychotic drugs. Acute muscle dystonia and extrapyramidal side effects. So acute muscle dystonia may occur after a single dose, especially in children and girls. The anti-emetic dose is generally much lower than the antipsychotic dose, and the agent should be administered until the cause of should not be administered until the cause of vomiting has not been established, because otherwise the cause can be obscured. Now prochlorperazine, the D2 blocking phenothiazide is a labyrinthine suppressant. They have got selective anti-vertigo property and anti-emetic action. Highly effective when given by injection in vertigo associated vomiting and to some extent in chemotherapy induced nausea and vomiting. It is used as an anti-emetic as well, but not as an antipsychotic. Muscle dystonia, extrapyramidal side effects are the prominent complication with the drug. Dystonic reactions are more common in children. Parenteral use in children is not recommended because of the dystonic reactions. Coming to the prokinetic drugs, what they are causing? They are causing forward propulsive movement of the intestine. So these are drugs which promote gastrointestinal transit. They speed up gastric emptying by enhancing coordinated propulsive motility. Now, in the prokinetic drugs, anticholinergic drugs, cholinomimetics and anticholinesterase drugs are not included. Why? Because prokinetic drugs, they cause coordinated propulsive movement of the intestine, while the anticholinesterase or the cholinomimetic drugs, they cause basically uncoordinated tonic contraction of focal tonic contraction of the intestine. Now metoclopramide. Now coming to the prokinetic drugs one by one, metoclopramide is the substituted benzamide drug. It was initially marketed as gastric herring agent in 1970. They act in the gastrointestinal tract as well as in central nervous system. They act in various receptors. D2 receptor antagonism is one of the method. Then they are acting on the 5-HT4 and 5-HT receptor as well. So their action is on GIT as well as in central nervous system. In the gastrointestinal tract, their action is more limited to the upper gastrointestinal tract, and they increases gastric peristalsis while relaxing the pylorus and the first part of duodenum. Thus they speed up the gastric emptying, especially if it is slow. Lower esophageal sphincter is tone is increased and gastroesophageal reflux is opposed. It also increases the intestinal motility, but their action is not there on the colon. So it has got no action in the colonic motility, only in the stomach and partly in the intestine. Central nervous system, it is an effective anti-emetic drug acting on the chemoreceptor trigger zone. It blocks the apomorphine induced vomiting. The gastrokinetic action may contribute to its antiemetic action. The problem with the drug is again because of its D2 blocking action, extrapyramidal side effects and acute muscle dystonia along with hyperprolactinemia because of D2 antagonism in the pituitary gland. So, it's here extrapyramidal and prolactin secretion augmenting action of the basically chlorpromazine. Pharmacokinetics, rapidly absorbed orally, enters brain, crosses placenta, secreted in milk, partly conjugated in liver, excreted in urine, half-life 3 to 6 hours. It was about D2 antagonism. Again, the other receptors it is acting 5-HT4 agonism. Now 5-HT4 receptors, they are present in the pre-junctional neuron of the intrinsic primary afferent neuron of the enteric nervous system. Now by basically having agonistic action on the 5-HT4 receptor, they are ultimately increasing the acetylcholine release from the basically myenteric neurons, and thus they are promoting the gastrointestinal motility. They act on the gastrointestinal tract to enhance acetylcholine release from the myenteric motor neurons. This results from 5-HT4 activation on the intrinsic PAN, that is primary afferent neuron of the enteric nervous system. Now they have also got weak 5-HT3 beta, 5-HT3 antagonism. Now at higher concentration it is blocking basically the 5-HT3 receptor present on the inhibitory myenteric interneuron, and by blocking it basically it is augmenting the acetylcholine release in the gut. Now interaction, now as it is slowing the gastric, as it is increasing the gastric emptying time, as it is increasing the gastric emptying, certain drugs like aspirin, diazepam and digoxin, their absorption can be delayed, and by blocking the dopamine receptor in the basal ganglia, they are opposing or they abolishes the therapeutic effect of levodopa. Levodopa, how it is acting? Important question, why levodopa is combined with carbidopa? Action bolo tumi bolo. To reduce the peripheral, how? It is not to reduce the peripheral side effects. To increase the efficacy of levodopa, it is combined with carbidopa. Levodopa basically is a prodrug that is converted in the body to dopamine both centrally and peripherally. Now what happens? Levodopa as such has got basically levodopa as such, they crosses blood brain barrier and enters in the brain and is converted to dopamine. Now to convert into dopamine, there is a role of dopa decarboxylase which is present both centrally and peripherally. Now this carbidopa, they are peripheral decarboxylase enzyme inhibitor. So they are inhibiting the peripheral decarboxylation of levodopa. Levodopa concentration is increased peripherally and more levodopa is available to cross the blood brain barrier and enhance efficacy. Now adverse effects, generally well tolerated, sedation, dizziness, loose stool, muscle dystonia, especially in children, are the main side effects. Long term use can cause Parkinsonism, galactorrhea, gynecomastia because of hyperprolactinemia, but it should not be used to augment lactation. No harmful effects are known when used during pregnancy, though the amount secreted in milk is small, but even the suckling infant can develop muscle dystonia, myoclonus, loose motion. Uses as an antiemetic, effective and popular drug for many types of vomiting, less effective in motion sickness. Gastrokinetic, to accelerate gastric emptying for following reasons. When general anesthesia has to be administered, but the person has taken meal within 4 hours, in that case the drug can be helpful. And to relieve post-vagotomy or diabetic gastroparesis associated gastric stasis. Dyspepsia and other functional gastrointestinal disorders, they cause symptomatic relief, gastroesophageal reflux disease, they may benefit in milder cases of gastroesophageal reflux disease. But the drug of choice is proton pump inhibitors. Now domperidone, unlike metoclopramide, its main action is on dopamine D2 receptors only. So it's a D2 receptor antagonist chemically related to haloperidol but pharmacologically related to metoclopramide. The anti-emetic and prokinetic actions have a lower ceiling effect, so less efficacious than metoclopramide. Unlike metoclopramide, its prokinetic action is only on D2 receptor blockade in the upper GIT and is not attenuated by atropine. Domperidone crosses blood-brain barrier poorly, unlike metoclopramide. So the basically extrapyramidal side effects are rare with domperidone compared to metoclopramide, but hyperprolactinemia can occur. The anti-emetic action is exerted mainly through the chemoreceptor trigger zone, which is not protected by blood-brain barrier. Because of poor entry into central nervous system, it does not block the therapeutic effect of levodopa. Absorbed orally, bioavailability only 15% due to first pass metabolism. It is completely biotransformed and metabolites are excreted in urine. Plasma half-life 7.5 hours. Few side effects: dry mouth, loose stool, headache, rashes, galactorrhea are generally mild. Primarily used as an anti-emetic only for mild to moderate case. It is not effective in severe cases of vomiting. It is also not useful in motion sickness and is not advised for morning sickness. Efficacy in chemotherapy-induced nausea vomiting is low. তোমাদের পরীক্ষাতে কিন্তু অ্যান্টিএমেটিকে মেটোক্লোপ্রামাইড, ডমপেরিডন, অনডানসেট্রন পড়াবো, কিন্তু খুব ইম্পর্টেন্ট আছে, এগুলো জানতে হবে। what is the mechanism of action of metoclopramide? Metoclopramide D2 antagonism, very good। আর কি হবে? আর সেরোটোনিন উপরে কাজ আছে 5-HT4 agonism, 5-HT3 antagonism, weak 5-HT3 antagonism। ইম্পর্টেন্ট সাইড এফেক্টস কি আছে? এক্সট্রা পিরামিডাল সাইড এফেক্টস। আর কি আছে? হাইপারপ্রোল্যাক্টিনেমিয়া, ঠিক আছে। ডমপেরিডন সঙ্গে মেটোক্লোপ্রামাইড তফাৎ কি আছে? হোয়াট দ্য ডিফারেন্স? তাতে কি লাভ হবে? হোয়াট দ্য বেনিফিট? তাতে বেনিফিট হবে এক্সট্রা পিরামিডাল সাইড এফেক্টগুলো কম পাবো আমরা। তো এক্সট্রা পিরামিডাল সাইড এফেক্ট ডু নট আকার কম্পেয়ার টু মেটাক্লোপ্রামাইড, এটা একটা। আর কি ডিফারেন্স রয়েছে? এটা অনলি D2 রিসেপ্টর অ্যান্টাগনিস্টিক কাজ রয়েছে, নো অ্যাকশন অন দি সেরোটোনিন রিসেপ্টর। ওকে। সিসাপ্রাইড, আমরা metoclopramide পড়লাম, which has got action on the upper GIT but no action on the colon। আর একটা ডিফারেন্স আছে, domperidone is less effective compared to metoclopramide। আচ্ছা, একটা পড়লাম metoclopramide and domperidone যাদের অ্যাকশন is limited only to the upper GIT। Now this drug has got action on the intestine, stomach and the colon। Okay, so it's a benzamide derivative, it's a prokinetic with little anti-emetic property because it lacks D2 receptor antagonism। Its main action রয়েছে on the serotonin receptor। Now effects of cisapride on gastric motility resemble metoclopramide, that is gastric emptying is accelerated, ileus tone is improved, esophageal peristalsis is augmented। It restores and facilitates motility through GIT including colon। Metoclopramide, domperidone do not accelerate colonic transit। Okay, its action is exerted through mainly 5-HT3 agonism which promote acetylcholine release from motor mesenteric neurons aided by weak 5-HT3 antagonism। Now because of its action on the colon in the serotonin receptor, it also increases the CAMP dependent chloride secretion in the colon that is responsible for the loose watery stool, one of the side effects with cisapride। it is devoid of action on chemoreceptor trigger zone. It does not produce extrapyramidal side effects, do not produce hyperprolactinemia because of lack of D2 receptor antagonism. Now, the problem is that the drug has been banned in many countries including India. Why? Because this drug is associated or linked to the serious ventricular arrhythmias. Why? It has been seen that when co-administered with CYP3A4 inhibitor, the drug level is increased because these CYP3A4 inhibitors, they decrease the metabolism of cisapride, and because of increase in drug level, what they are causing, we know in the phase 3 of the cardiac action potential, delayed rectifier potassium channel opens up. Now they are blocking these potassium channels, so what happens? There is prolonged QTC interval, and that is responsible for fatal ventricular arrhythmia called torsades de pointes. So, it blocks the delayed rectifying potassium channel in heart, prolonging QTC interval and predisposes to torsades de pointes or VF. Following such reports, the drug was suspended from marketing in most countries several years back, but was available in India till it was banned in March 2011. Now coming to the next drug, mosapride. It's a congener of cisapride with similar gastrokinetic and aleastonic action due to 5-HT4 agonistic and 5-HT3 antagonistic action. Like cisapride, it is clinically useful antiemetic. It has got no action as an antiemetic, but does not produce EPS or hyperprolactinemia, similar to that of cisapride. Side effects are loose motion, abdominal pain, headache, dizziness and insomnia. Some reports of QT prolongation has been seen with the drug, but still the drug is available in the market, but should be used with caution. So, some reports of QT prolongation and arrhythmia have appeared after general use. Its plasma concentration is also elevated by CYP3A4 inhibitors like antifungal drug azole. Though it has not been banned, it may not be safe and as considered earlier. Indications are non-ulcer dyspepsia, diabetic gastroparesis and gastroesophageal reflux disease. Etopride. Now etopride is another substituted benzamide produced in Japan and promoted as prokinetic drug. Now action on D2 receptor antagonistic action is there, and anticholinergics activity is also there with low affinity for 5-HT4 receptors. They are unlikely to cause cardiac arrhythmia in healthier volunteers, so more safer compared to cisapride and mosapride. This may be due to low affinity for cardiac 5-HT4 receptors. Metabolized by flavin monooxygenase, so their concentration is not increased by taking CYP3A4 inhibitors. Okay. Side effects are diarrhea, abdominal pain, headache, galactorrhea and gynecomastia occur infrequently. No extrapyramidal side effects are seen. Indications are similar to those of other prokinetic drugs. Levosulpiride. Now, they block central as well as peripheral D2 receptors and has got atypical antipsychotic action as well, prokinetic and antiemetic properties. Because they act both centrally as well as peripherally in the gut, it has been used mainly for symptomatic relief of several gastrointestinal disorders like ulcer dyspepsia, nausea, bloating, GERD, irritable bowel syndrome. Cinetapride is a gastrokinetic drug developed in Japan, developed in Spain and marketed in Spain, Mexico, Argentina and India. Action on 5-HT2 receptor, antagonistic action, dopaminergic D2 receptor action royeche, and they have got 5-HT4 agonistic action, indicated in functional gastrointestinal disorders. Now, comparative value with other prokinetics has not been adequately evaluated. Driving is not advised because of drowsiness. Other side effects are diarrhea, muscle dystonia, mental confusion and allergic reaction may occur. No QT prolongation has been seen with the drug. Ondansetron is a 5-HT3 antagonist. It was developed for the action on the chemotherapy-induced nausea vomiting. Chemotherapy-induced nausea vomiting, most of the drugs are ineffective. In that case, ondansetron is very effective drug. Now, generally, যখন chemotherapy টা পড়ি আমরা, they have got different levels of emetic action. Some drugs are highly emetic, some drugs are lower emetic. The highly emetogenic chemotherapy, one of the drugs is cisplatin, and the various drugs are basically tested whether they are effective in cisplatin induced vomiting or not. Cisplatin causes vomiting in two phases. One is acute phase that occurs within 24 hours, and one is delayed phase that occurs in 2 to 5 days, over 2 to 5 days. Now, this ondansetron alone is effective in acute vomiting caused by cisplatin. They are less effective in delayed vomiting, where some other drugs has to be added. We are coming, huh? Ondansetron is a prototype of a distinct class of anti-emetic drug developed to control cancer chemotherapy, radiotherapy induced vomiting. But they are later found to be also effective in post-operative nausea vomiting and disease or drug associated vomiting. They block the depolarizing action of serotonin through 5-HT3 receptor. Cytotoxic drugs, radiation produce nausea and vomiting by causing cellular damage in the gastrointestinal tract, causing release of serotonin from the enterochromaffin cells. Now, in ondansetron, they blocks emetogenic impulses mainly at the peripheral origin in the GIT and at their central relay. It does not block dopamine receptors. Vomiting induced by apomorphine or motion sickness are not suppressed. They are ineffective in motion sickness. A minor 5-HT4 antagonistic action has also been shown, but seems to have no clinical relevance. Oral bioavailability 60 to 70%, hydroxylated by CYP1A2, 2D6, 3A, followed by glucuronide and sulfate conjugation. No clinically significant drug interaction in patients with vomiting not responsive to ondansetron alone. In that case, adjuvant antiemetics can be added, like dexamethasone, like aprepitant is a NK1 receptor antagonist, and basically and other antiemetics. So, addition of dexamethasone, promethazine, diazepam or both, or dexamethasone plus NK1 antagonist aprepitant can be added with them. Adjuvant drugs are more often required for delayed type of vomiting that occur on the 2nd to 5th day of cisplatin therapy in some. Ondansetron alone is less effective in delayed vomiting than in acute vomiting, which occurs within 24 hours of cisplatin dose in all patients. Efficacy of the drug in prevention and treatment of post-operative nausea vomiting is now well established. Since the vomiting is multifactorial in origin, many other classes of anti-emetic drugs are also effective in post-operative nausea vomiting. Superiority of the ondansetron in efficacy and safety has been demonstrated over ondansetron and domperidone as well. Vomiting occurs as side effects of drugs or due to drug overdose. GI disorders, uremia and neurological disorders are also suppressed. Efficacy in motion sickness is poor because they have got no action on the histaminergic or anticholinergic receptors. Should be used in pregnancy only when unavoidable. Well tolerated, headache, dizziness are milder side effects, mild constipation, abdominal discomfort can be seen. The drug of choice in case of cancer chemotherapy is ondansetron, not any other drug, right? It can come as MCQ. Granisetron, 10 times more potent than ondansetron and probably more effective during repeat cycles of chemotherapy. After chemotherapy arambho howar por it occurs in cycles, like 6 cycles of chemotherapy or 20 cycles of chemotherapy. Now, as we go each cycle one by one, the efficacy of anti-emetics start to decrease. Now, this granisetron, they are more effective during repeat cycles of chemotherapy. They are 5-HT3 antagonists definitely, and 5-HT4 receptor কাজ কিন্তু এটা ondansetronটা ছিল, they were active also on the 5-HT4 receptors, but this granisetron they are more specific for 5-HT3 receptor. Weak 5-HT4 blockade not seen with the drug. Plasma half-life longer, needs to be given only twice daily. Side effect profile similar to that of ondansetron. Palonosetron is more specific for 5-HT3 receptor, longest acting, highest affinity for 5-HT3 receptor. They are more effective in suppressing delayed vomiting. They are more effective in repeat cycles of chemotherapy. It is only drug of this class approved by US FDA for delayed chemotherapy-induced nausea vomiting. Ramosetron is a potent 5-HT3 antagonist developed by Japan. Properties similar to that of ondansetron. Its indication is basically chemotherapy-induced nausea vomiting, post-operative nausea vomiting, and again they are useful in diarrhea predominant irritable bowel syndrome. NK1 receptor antagonist. Activation of NK1 receptor in the chemoreceptor trigger zone and nucleus tractus solitarius by substance P due to emetogenic chemotherapy and other stimuli play a role in vomiting, and by blocking this receptor basically NK1 receptor antagonists they show anti-emetic action. Aprepitant is one of the prototype drug for the NK1 receptor antagonist. They are selective high affinity NK1 receptor antagonist. They blocks the emetic action of the substance P. They enhance the anti-emetic efficacy to protect up to 90% against high emetogenic cisplatin based chemotherapy. They are basically combined with ondansetron in case of cancer chemotherapy induced vomiting, particularly in delayed phase of vomiting. Greater additional protection was afforded against delayed vomiting than with acute vomiting. Now, it is also particularly useful in multiple cycles of chemotherapy, and they are equally effective as ondansetron also in post-operative nausea vomiting. Tolerability is good. Now coming to the adjuvant anti-emetics. Probably their action is due to the anti-inflammatory action. They are employed to augment the efficacy of other primary anti-emetic drugs. They are used both in case of acute and delayed emesis. They also serve to reduce certain side effects of the primary antiemetics. Now benzodiazepines, their anti-emetic action is probably due to the sedative property, and they help by relieving psychogenic component of the vomiting, by reducing the anticipatory vomiting, and also producing amnesia for the unpleasant procedure. They also reduce the dystonic reaction of the metoclopramide and can be combined with it. Cannabinoids, basically tetrahydrocannabinol possess anti-emetic activity against moderately emetogenic chemotherapy. Dronabinol is a pure tetrahydrocannabinoid basically synthesized or extracted from the cannabis. They have got hallucinating, disorienting and other central sympathomimetic effect, and they produce addiction. They are promoted in the market as an appetite stimulant as well. Digestants, these are the drugs that promote digestion. They contain basically proteolytic, amylolytic and lipolytic components. They are promoted in the market also as appetite stimulant and as health tonics. Their routine use in the patient should be avoided. It's irrational. They can be used where the digestive enzymes are decreased in the body. Include pepsin, papain, pancreatin, diastase and takadiastase. Now coming to methyl polysiloxane, also called dimethicone dimethyl polysiloxane. It's a silicon polymer containing amphiphilic liquid, viscous liquid. They act as an antifoamic agent, and they collapses froth, and basically they help in to relieve gas from the body. The most common complaint in the Indian patient is complaint of gas. The abdomen gets bloated with the food. So, in that case the drug, by relieving the gaseous distension, they help into relieve some symptom. Not absorbed from GIT, they are pharmacologically inert. They are promoted as a remedy for gas. They are claimed to coat and protect ulcer surface as well. They aid dispersion of antacid in gastric content and they prevent reflux as well. However, clinical efficacy is equivocal. Now, gallstone dissolving drugs. Gallstone basically termed as cholelithiasis. The treatment of choice is cholecystectomy. Better to say laparoscopic cholecystectomy. But in certain cases, the operation can be contraindicated or not possible. In those cases, medical therapy can be an option. High cholesterol is to bile salt ratio, they favors crystallization of the cholesterol crystals that act as a needles over which the stone formation occurs. Now what happens? There are two drugs that can be used to dissolve gallstone. One is chenodeoxycholic acid, also called chenodiol, and ursodeoxycholic acid, ursodiol. What they cause? They decrease the cholesterol content in the bile and hence they enable the solubilization of the cholesterol from the stone. Now this chenodiol is not used nowadays. Why? Because of lower efficacy, number one, because they may increase the transaminase level in the liver, number two, they frequently cause diarrhea and they can increase the LDL cholesterol. For these four reasons, chenodeoxycholic acid is not used for gallstone dissolving and the drug of choice is ursodeoxycholic acid. Ursodiol or the ursodeoxycholic acid is the hydroxy epimer of the chenodiol. It is more effective, needs to be given at lower doses. Now administered orally, well absorbed, gets conjugated in liver and with glycine and taurine, excreted in bile. They show enterohepatic circulation and hence they have got longer half-life, about 4 days. It promptly reduces cholesterol secretion in the bile, promote solubilization of the cholesterol crystals of the stone by liquid crystal formation. It also inhibits the intestinal cholesterol absorption. Now plasma LDL cholesterol is not raised, unlike chenodiol. It can achieve complete dissolution of the cholesterol crystals in up to 50% of the subjects, but it has to be given for 6 to 24 months. It is more likely to succeed in patients who have a functioning gallbladder and there are multiple floating stone in the gallbladder. In those cases, it may be effective. Diarrhea, rise in hepatic transaminase level is infrequent. It is much better tolerated than chenodiol. However, gastric mucosal damage may occur leading to ulceration, so they are avoided in peptic ulcer patients. Dissolution of gallstone is a very slow process. Patient compliance is very poor. Once discontinued, recurrence is also common. Repeat courses may have to be given.